name is Dr. Patti Peeples, and welcome to the next episode of Patti's People, sponsored by the Evidence Base. When you sit across from Dr. Eberechukwu Onukwugha, known as Ebri, you realize quickly this is not just an academic who speaks numbers. This is a woman who listens to them. A professor in health outcomes research at the University of Maryland, also the executive director of Pharmaceutical Research Computing and the immediate past president of ISPOR, Dr. Onukwugha is shaping how we define value in healthcare, but not just through models and metrics, but through a grounded, globally informed sense of equity. Her work spans claims data to state policy to real-world evidence to human insight. And in this conversation, we're going to talk to Ebri about the rigor of economics, the messiness of lived experience, and what it means to lead with both precision and presence. Welcome, Ebri.
Thank you, Patti. Thank you so much for having me.
What is something that people might be surprised to learn about you that has absolutely nothing to do with your work, but it has informed how you show up in life, both personally and professionally?
Thanks for that question. I should probably share again that my name is of Nigerian origin and one that I am very proud of. And one thing that might surprise a lot of people is, as a new assistant professor joining the field, this was back in 2006, I was advised by a colleague that I'm probably better off publishing under a different name, maybe even adopting a pseudonym that was more acceptable. And that would be necessary for me to be successful in academia. Mm-hmm. I thought the advice was well-intentioned, although mistaken. But the way that it shaped how I show up is that it made me realize that there may be others who have received such advice. I may also have been a person who provided well-intentioned but mistaken advice, and so I needed to be really aware of that. So I resolved to stand out and stand tall, really, for that principle, both in my personal and professional life. So an example from the professional life is really thinking about whether or not it's advice on publishing, as that one was, or any other academic or professional setting, that I was really wanting to be careful not to limit people. And not limit them by what I perceived to be their skills, because this was not the case with that advice that I got. Mm-hmm. It was the perception as to what the world would allow them to accomplish. Mm-hmm. And that I could sometimes be mistaken in that, as this individual was mistaken in what they thought the world would allow or create room for. And so I've been very intentional that I'm supportive, a listening ear, always just available to hear and create space for barriers to be shared so that I can be helpful in that regard and encouraging. Because in that moment, that's what I needed, was encouragement. And so I want to be sure that I'm providing that. And then in my personal life, as a mom of 4 kids, I have always kind of thought about, make sure you're thinking about how you can support and encourage, but importantly, that I'm not limiting them based on what I think the world will allow for them. Mm-hmm. And so that's really shaped a lot of the way that I raise my girls and have raised them, and also how I mentor and teach, interact with colleagues.
Mm-hmm. You know, I was listening to an interview just this weekend. Evidently, there's a book coming out from an author of The Atlantic, and an author that writes for The Atlantic Journal. And the bottom line was advocating for doing away with demographic categories because so many feel that it is reductive. And it makes me think that as researchers, it's probably quite worthwhile for us to check ourselves periodically if the way that we are meeting people through our research methods is reductive for the sake of analytic capabilities, but what are we losing when we do something like that?
Yeah, that certainly that threat of reductionism always exists when you're studying phenomena that we acknowledge we don't fully understand. So it is a line that we walk anytime we're conducting research, particularly on social phenomena, because there's a lot of complexity and nuance there. I would say that, it's been great to see some progress in terms of OMB's expanded categories that were launched in 2024. That certainly the data have to catch up with that, but it's been exciting to see some intention there. But it's also the case that, yes, we do risk saying we've done enough. Supposing we met OMB's new categories with a particular data set, there is a danger that we think that that's enough. And so I certainly would submit that collecting data on race, ethnicity, sociodemographics, risks reducing the concept to something that is observable. Whereas for many patients, a lot of what they determine to be their source of identity or value or purpose is not observable. And so we do have to walk that continuous line in beginning somewhere, which is having these measures available and certainly not reducing our access to them, but using it really as a launching off point for greater investigation into really what those nuances of those barriers. And so it's continuing those conversations with patients while we recognize the barriers of our data, I think will be important.
It just underscores that we always need to have direct patient interactivity in this world where data sources are expanding at the speed of light, that tells us only so much. So that's why I think this conversation is particularly important for our audience today. You try to walk this fine line between rigor and relevance, and particularly as our audiences, our stakeholders, who consume the kind of research you do, expands beyond just individuals that live in healthcare policy. Give me an example where the data clashed with your expectations, and then that changed how you see both.
Yeah. So, a lot of the work that I've done in the health services space, health economics and outcomes research is in the oncology setting. And one of my early studies examined treatment receipt and physician visits among men diagnosed with prostate cancer. This is using data from 1994 through 2002. So we had a good for studying receipt of treatment and interaction with physicians. And the data set allowed us to develop generalizable results because it was data from the NCI, the National Cancer Institute, a really well-known data product. And I focused on men diagnosed with incident stage 4, so already a high need, vulnerable population. And I remember, although this was not our primary question because we're looking at treated populations, but you do have to start with your base population and in that identify who received treatment. And we're focused on hormonal therapy, chemo, or orchiectomies. It surprised us and in fact shocked the clinician on our team, our urologist, that 23% of these men did not receive treatment. And so the question becomes, you're diagnosed with stage 4, you have insurance, we know we have visibility to all your healthcare because we excluded people who were enrolled in Part C, so Health Maintenance Organization. And so we felt comfortable that we weren't missing out on key care that was received. So why are nearly a quarter of the individuals not receiving any cancer-directed treatment following diagnosis of stage 4 prostate cancer? That surprised me. And in that population of men who were not treated, a large proportion of them had not seen a urologist. I think it was in the 60% range. Also in the mid-60s proportion had M1 disease, which is your true metastatic diagnosis. So a couple of things I learned from that is that it's important to understand the intersections of experiences. So not only not receiving treatment, but oh my goodness, they had M1 as well and had not seen a urologist. What is the implication of all of that in terms of outcomes among the not treated.
Mhm.
And another thing it highlighted for me is that we have to look at a more sort of richer level if we're trying to understand what we consider to be something that's unusual, maybe even rational, certainly unexpected. And that got me down the path of looking at non-patient level factors. And in fact, a follow-up study that I published a few years later examined contextual factors we linked to census data, investigated non-treatment, and factors based on SDOH, differentially for Black and white men, and saw differences there, partly explaining some of those events that we had identified in the early study.
Mhm.
And so I've continued that interest in contextual factors since then.
You continue to work with massive data sets, but you've given an example here where a subset of patients informed your research approach. Is there an example where a single patient story shifted your thinking more than 1,000 rows of data?
Indeed. Another area of interest for me in my early career was studying hospital discharges and understanding discharge outcomes following a hospital stay, and then looking at readmissions. A lot of interest at the time in costs associated with these readmissions and trying to understand what predicts a readmission. And so, as you mentioned, the data sets were large. I had 500,000 people, 2.6 million discharges in one particular data set that I remember. But I also, at that time, was very interested in the why and understood that I needed to talk to people who have discharged, and conducted mixed methods research in that regard. So interviewed individuals from 4 area hospitals to understand their reasons for leaving. And I was particularly interested in those who left against medical advice, to understand sort of the rationale from their perspective. And I learned 3 things from that investigation in terms of mixing those methods of qualitative and quantitative inquiry. One is that a patient story, a single patient story, can impact how I approach model specification in terms of the factors that are important in that model. I also learned very clearly that the quantitative data, regardless of the sample size, can miss out on important factors.
Yeah.
And we heard that from our patients in terms of factors that were important to them. And this concept of measure invariance is another one that I'll explain, but that became very clear to me from this work. And so the first one about the model specification, talking to a patient about how they approach that discharge process, why they left and what happened, they said, well, I wasn't treated well at the first hospital. In fact, was treated quite poorly. Another hospital was within 4 to 5 blocks away. And so it was easy for me to leave hospital A and go to hospital B in hopes of getting better care. And so with that, it became clear to me that I need to include distance from the hospital as an important factor predicting a readmission. And it became one that I used consistently because I saw its value quantitatively. But I wouldn't have thought of that until I talked with patients. Then another kind of aspect in terms of the clarity that came from understanding that the quantitative data can be lacking. When you heard from them the reasons why they left, it was things like, for cultural reasons, I requested a female physician to provide care, and a male physician showed up, or the staff were rude or disrespectful to me, and so I left. Or the hospital was dirty, my room wasn't clean, and that made me think, what kind of care are they providing to me then? These are measures that are hard to, or impossible to capture with administrative data, but clearly are drivers of behavior for patients. So that made me realize that we need to certainly be careful in terms of how we interpret our quantitative if we're missing key variables and predictors. And then the thought I shared about measure invariance was another one that really resonated with me. We had one individual providing an interview talking about why they left and how they thought about their care, and mentioned that oftentimes they felt ignored by the staff. The hospital felt too quiet. In fact, their room was too quiet. No one came in, no one cared after them, and that made them feel unseen.
Yeah.
And then I thought as well about some quality metrics we used for hospitals at the time. And one of the metrics used for assessing the quality of a hospital was, is it quiet at night?
Mm.
And I think the thought there was, if it's quiet, the patient can sleep and,
Yeah.
get some rest. And so that's a good indicator of quality care for this nationwide quality metric.
Yeah.
But we heard from patients that, for some of them at least, that would not be a sign of good care. And so it's important to take any measure and investigate whether or not that construct that we are attempting to capture is interpreted the same across different groups and geographies, before we start using that metric to compare experiences across groups.
Really, really great case study there. You have just moved into the past president role, immediate past president role of ISPOR, having led with great professionalism the organization for this past year. Reflecting on your time as ISPOR president and the role that you'll now play, what conversations are we still not having loudly enough in HEOR or in HTA circles?
Yeah, no, thank you for that. It certainly was a privilege of a lifetime to serve in that position with ISPOR, and look forward to the year ahead as past president. Certainly get exposed to the breadth of HEOR in terms of the different countries and researcher kind of questions that are arising from different geographies. So I really value that opportunity to get that much broader view. And so a lot of conversations are happening, which is very exciting. Our data sets are getting richer. The complexity, the size, the capture over time, how generalizable they are, linkages. There are a lot of exciting developments, certainly. One of the more exciting ones for me as a person who uses real world data is to see the expanding regulatory use cases for RWD, for real world data. So I've been very excited to see that. And amidst all of that, I would say I wish we could have more conversations about measures. And by that, I mean, we have data that are becoming larger, but my question is, are they becoming more informative?
Yeah.
And so this idea of information contained therein, is that actually growing? And to address that, I think we need to sort of back to basics. What are the theoretically grounded measures that we know are important from theory and from our frameworks? What are the measures that we've heard resonate with patients? And really have that drive data collection. And a lot of the data I use are administrative. And so it's sort of, you're working with data already collected, oftentimes for different purposes, not research. But there's also room for taking what we're hearing from these patient panels, such as you referenced, and other engagements with decision makers, to then inform the data we collect. And so is that costs from the patient's perspective? Is that better measures of income, where we're looking beyond take-home pay to what you keep, right? And then with ISPOR, I've become involved in an initiative focused on whole health. I published a commentary this past spring with Rob Abbott and Laura Pizzi on that topic. And so what does that mean then for data collection in terms of how we're capturing these broader dimensions of health?
Yeah, I think it's such an important conversation to continue to have and to speak loudly about it, because every day there's a more and more of a false sense of security with the size of the data sets, and particularly through AI, that gives us a sense that we have greater understanding than ever before. But in fact, if there's misrepresented measures that are not completely indicative of the true outcome, or if there are data that are weighted equally when they're not equally valid and reliable, then we run the risk of not paying attention to this. And I think it's only going to be compounded over the years. So your voice will need to have to get louder and louder and louder. Now, you've warned that, speaking of AI and machine learning, you've warned that they risk widening skill gaps.
Mhm.
What do you mean by this?
Yeah, I absolutely, it's something I think we need continued attention to, because AI and ML, particularly in health economics and outcomes research, is finding greater and greater application. And we can see that from our conference abstracts at ISPOR and other conferences, at papers being published in the various journals. And I think that's exciting and very much welcomed. Where I think about technological progress, typically it's this idea of doing more with less. And that happens, and certainly being evidenced in AI and ML applications. But what I say we need more attention to is the diffusion of this technology, access to this technology, and that's not automatic. That will be equitable, and because I think that has to then progress through whether it's civil, social, financial, different legal norms and structures. And so it's not automatic that people who should have exposure to these methods would gain exposure to them. And so I don't think we should assume that everyone who doesn't use AI and ML either doesn't want to or is not interested. It may simply be access barriers and information barriers.
Drill down on that. Give me an example of a group that doesn't have access. What are the consequences, and what might be the way to level the access field?
So one thing I see as an educator in terms of, for example, applications to our graduate program is in terms of work that applicants have either added to their CV or can demonstrate that they've been able to do. And there are clear differences that I see year over year in terms of the ability to present research or even produce research that uses AI and ML.
Got it.
And a lot of it could be quite simply not having exposure to that in the classroom, not having faculty members who can either mentor that kind of work, but the students are hungry, but maybe lack an environment that supports that.
So how do you address something like that on those applications? How do you rebalance that variable that they're falling down on through no fault of their own?
Agree. So a lot of that, I think by the time we are seeing it in the application, from someone in my perspective, in my position, it's late to act on that particular cohort, if you will, because we do have to assess what's in front of us for the purpose of admission. But it does get me thinking about, well, how can I be in front of the next set of applications that are coming, either next year or in 2 years or 3 years? And how do I support opportunity to learn these methods? And that was something I had discussions quite often with internal staff at ISPOR. Was very happy to see ISPOR take continued front lead on that in terms of training opportunities internationally. So that's one way. But I would say generally as a framework, the 3 words that come to my mind would be care, connect, and collaborate.
Yeah.
And so the first thing is we have to care that some people don't have access, connect with them. And I wanted to do that and did a lot of that at ISPOR conferences, is talking to our members, hearing where their training barriers are. What are methods you're hearing at this conference that are new to you that you wish you had learned more about? And I learned a lot about barriers. And then opportunities to collaborate, for us to share what we know as educators, talk to the in-country experts about use cases, opportunities to collaborate and apply those methods in their country setting, and even improve how we deliver training based on the country setting. So I think there's so many opportunities for bidirectional learning when it comes to this sort of care, connect, collaborate approach.
Or simply means-based pricing on access to the conference and the educational opportunities.
Absolutely.
You are taking a look at measures from behavioral science in your research, looking at access and utilization. We've talked a little bit about this. Are there any other example measures that you are advocating be
Mm,
in order to give a greater understanding of how those impact access and utilization?
mm.
Basically, how can your interest in behavioral science, what can we learn from that in terms of improving health outcomes?
Yeah, no, thank you for that question. I mean, I'm a behavioral scientist at heart,
Yeah.
having trained in economics with all my degrees, my formal degrees. And so I see a lot of untapped potential across the behavioral sciences in terms of measures that we can adopt as we think about the behavioral outcomes we examine in health services. So one example that has resonated with me and really kind of stuck with me over the years was a study that I was involved in looking at transmission among individuals who are HIV positive, some mother to child transmission, and use of antiretroviral therapy in those populations of mothers. And the fact that adherence was poor, in fact, surprisingly poor. And again, this gets back to why wouldn't you kind of thing, questions arising as we had experience with the prostate cancer analysis. As a mom, knowing you're HIV positive and pregnant, what and being provided access to this therapy, what then would lead to moms not wanting to engage and to be on therapy, knowing the risks to mother and baby. And we learned from qualitative interviews that many of the moms did not want their husband knowing they were HIV positive. And so going on therapy was a risk for them.
Mm-hmm.
And that there were other social and cultural barriers and nuances that entirely drove their behavior, different from access to medication. And so understanding the role of behavioral therapy, about which there's a lot of evidence outside our field, self-esteem and how that impacts your ability to activate as a patient.
Yeah.
It's been to me fascinating to think about that parallel work and how we might leverage that to improve our interventions.
Yeah, shame, fear, self-esteem, all of those things that are really innate in driving how we show up in this world.
Absolutely.
In addition to not gathering some of those behavioral outcomes, you've also talked eloquently about the fact that a lot of the data sets ignore key economic realities for patients: disposable income, opportunity cost, uh, burden of caregivers. Gets a little bit of talk in our area, all the non-medical cost. Give me some examples of how this is shown up in your research, and what else do we need to do here other than just recognizing that they don't exist in our limitation sections?
Mhm, mhm. Yeah, absolutely. I think we need fundamentally more empirical evidence as to does it matter that we have these measures? So we have income measures. If we collected information on disposable income, which is net of taxes, if we collected information on discretionary income, which is net of basic care needs,
Yeah.
and, for example, conducted a study with income, disposable income, or discretionary, would our conclusions have changed? I think that kind of research or that approach to understanding measures is lacking. And part of it is because we, in the US, for example, don't have a lot of good data sets that have discretionary or even disposable income measures. And so we lack the opportunity to even answer that question as which measure is more important for my HEOR outcome. So we need more of that. But I think fundamentally we need to want to see the world out from the patient's perspective
Yeah.
and understand what it's like to walk in their shoes, right? And so you mentioned opportunity cost. What am I giving up? What have I had to stop doing to be able to seek care, even the first time? right? Let alone multiple times
Yeah.
as you think about people along, for example, a cancer treatment journey.
Mm-hmm.
And then again, it's back to care, connect, collaborate. How do we get from knowing these measures are important to having them available to researchers like us, so that
Mm-hmm.
we can study this and develop evidence to support decision makers?
Yeah. I think something like that is front and center with us, and particularly in the state of Florida, where I live with, as access to Medicaid is being drastically considered and rolled out. Then, yes, healthcare options are theoretically available, but the disposable income factor is a critical measure in understanding whether or not that'll be chosen and what the options are going to be there, what the impact is going to be. So, you have focused most of your career in the university world, and you've talked a little bit about trying to be more sensitive to the extent you're able in looking at the applications and trying to ensure that you're training the right kinds of people.
Mhm.
But what do we need to think about in training that next generation of HEOR professionals, not
Mhm.
just to code,
Mhm.
knowing their methodologies, clinical skills, in terms of how they're applied in the real world? Where are we missing the mark?
Mhm. It's something I think out quite a lot, particularly as I've had more and more students graduate, join the working profession, and see how they've advanced in their career as well as others. Giving more thought to what we as educators can do to support that journey. And so, as you mentioned, many of our programs do an excellent job on the quantitative skills transfer, even kind of highlighting to students that this is a one-in-time transfer. And so it's on them to continue to investigate and invest in their
Mhm.
quantitative skills. I think we do a good job with that.
Yeah.
I don't think we do a great job with soft skills. And so, how do you get people to care about all skills? I think we need to be more transparent as professionals and explicit about what it takes to advance in a job, not just to get a job. So, a lot of our focus is often what is it going to take to get that first job?
Mhm.
But those of us who've been working for a while know that there's a lot more than to keeping that job, to be successful in that job, to build a career, and that job skills and career skills are not necessarily overlapping. And so I've worked with ISPOR on a competency framework that
Yeah.
was first published in 2020 and has since undergone revision. And I think that provides a wonderful platform for talking about sort of this broad-based training for career development of our HEOR professionals, so that they see also the value to themselves of career building and thinking about what I would call servant leaders as a word that comes to my mind.
Mhm.
I think we need more of that in the field as well, and not just talk about leadership development in HEOR, but development of servant leaders.
Mhm.
Um, One of my favorite quotes, Shirley Chisholm, many may know and remember as the first Black woman to serve elected to Congress. And I hope I get this quote right, but one of the quotes I remember from her is that service is the price we pay for the privilege of living on this earth.
Mhm.
And I love that because we certainly should be invested in our careers and being successful, but then how do we pay that forward, that privilege that
Mhm.
comes with that success?
Mhm.
And it is true, it is through training our HER professionals to be successful, reach back, and help others as well be successful in our field.
Well, I I think that I agree with you on service. However, I think it is also a little bit bigger than service. It is helping these researchers be, in the room where the discussions happen. And I think there is a distinctive path that our associations have generated which is pretty limited to industry, staying within the HEOR, RWE arena, academics, or HTA and consulting. There's not a lot of other avenues that are encouraged or presented. And HEOR people are, number one, there's hardly any, if any, there may be one that has moved into the C-suite in pharmaceutical companies. That really concerns me, because what it says is that those individuals are not thought of as key strategic minds. They are not thought of as having a global enough understanding of the role of the research manufacturer, and that they are to some extent being relegated either to the customer facing on market access or in a more analytical role. And I think that is the death knell for our profession.
I couldn't agree more. And it's something that we need more intention about. And I think it first begins with recognizing our training. What is it that we're bringing to the table? And are we bringing that broad-based strategic thinking grounded in research, but not certainly bounded by the research, that allows individuals in the C-suite to really think bigger? And one of the things that I've liked to do is, if we have 20% right and 80% not so right, I want to shine light on that 20% and say, how do we grow this? And so we've had in our graduate program, one of our alums who has been quite successful, C-suite at a company, come back and talk to our current students and say, what did they have to do to rethink or reshape how they approach themselves, how they presented themselves in their job setting that created that opportunity to now be in the C-suite. But there are too few examples of that. Absolutely agree with you.
The other area that I think is missing is being in the room where the discussions happen from a policy standpoint.
Absolutely.
Why do we not have HEOR people sitting on boards in their city that are on health access, advising and in conversation with journalists on what these changes mean in terms of changes to the ACA or changes to Medicaid access? Like, these are the voices that need to have confidence and the ability to articulate these impacts in an understandable way. And I think that our universities and our associations are right there at the intersection to help with that training. And I'd really like to see a much greater focus on that.
Yeah, absolutely. If I could share one thought on that, just from service opportunities that I've been privileged to be a part of, particularly in that regulatory space, learned that researchers, we need to be part of the conversation much earlier. And by earlier, I mean even at the stage of developing the regulation, because we bring knowledge about the how. What are the metrics? What are the data sets? What's feasible even? So, if you're interested in a policy to reduce cost-related non-adherence, for example, among individuals who are cost-burdened and need access to these therapies, well, you could have a metric, what it means to reduce CRNA, but it's not implementable with current data sets, or you haven't discussed, it hasn't gone far enough in terms of the metrics, or the metrics can be operationalized for your given state. And if you have state policy, but haven't articulated a way to, or a path to generate state-specific information, then you're left with sort of retrofitting published studies, which may be fine, but I think in the sort of spirit of the regulation, probably is not what the regulators would have wanted. But having researchers at that table of the policy writing phase, I think, can be very important.
So let's go to our lightning round with some fun, lighter questions. You ready?
Absolutely.
All right. You're hosting a dinner party. You get 3 guests from your professional life and 3 guests from any other walk of life, alive or not. Who are they and what are you serving?
Okay. Um, one guest I would definitely want to invite would be a patient, wouldn't say the name, but that I had interviewed back in 2008 for my hospital discharge work. I'd be curious to know if things have gotten better in
Mhm.
terms of hospital care since then. Rob Abbott, who is one of the most interesting people I know,
Mhm.
well-traveled, big thinker, easy conversationalist. I also would want to get time with an AVP for data informatics at a healthcare system. I think they are really at the nexus of a lot of interesting discussions. And then non-professional, Handel, because I love the Messiah.
Uh-huh.
And I'm intrigued with anybody who would say uh, that I should be sorry if I only entertain them. I wished to make them better. I love that quote, and I would
Yeah.
want to hear more about that. And
Yeah.
then the last two people would be third grade teachers from this last academic year and my third grade teacher. I'd
Oh,
want to be interested to hear how eighth graders have changed or not changed, 8-year-olds
yeah.
have changed or not changed. And serving food would be an eclectic mix of Nigerian food and American food, which is how I eat.
Uh-huh.
So it'd be jollof rice, which is a very traditional Nigerian dish, as is fried plantains, baked chicken, and roasted broccoli and spinach.
What a magnificent spread in both people and victuals. If you had unlimited time, money, and political will, what single problem in healthcare would you strive to solve?
To me, it would be what I think we have still been unable to solve in healthcare, which is providing the right data at the right time to the right decision maker. And so I would be all about investing in evidence generation, whether it's rapid analytics, finding ways to get the right information to people when they need it,
Mhm.
and whatever data infrastructure investment that would take.
Mhm.
That would be something I think would be important, because I believe in the idea that we have a lot of smart people who are capable. What they lack are the right inputs sometimes to make the right decisions. And
Mhm.
so anything I could do to release that barrier,
Mhm.
I would find worthwhile.
What keeps you up at night? Not professionally, but philosophically.
Mm, um, how do we get people to care more?
Mhm.
I think keeps me up at night. I was really moved by a story I read about, I think it might have been a K through 5 teacher, so certainly in the early grades, and how she identified loneliness among students I thought was really intriguing. She would have students pick each day someone that they interacted with. And then she
Mhm.
would go home and look at the names and figure out who wasn't getting
Yeah.
noted, right? And so um, then she would come back to kind of how do you get the students to care about that one student who wasn't
Yeah.
getting picked, or so I
Mhm.
always worry about who's being left behind and how do we get ourselves to care more about
Mhm.
that.
Mhm. I think about that a lot too. I think about it in terms of uh, one of the aspects of America is individualism, but I often wonder if that ethos has an eventual destructive
Mhm.
influence to it. There's such a balance between the individualism and the societal benefit. And right now, I think we, in this world of ours, are centered too much on the individual benefits of things. So I agree with you. How do we get people to care more about that?
I think there's definitely a balance for sure. I mean, I grew up in a culture that's very social and community based
Hmm.
and can see value in striking a balance
Yeah.
between the two. I
Mm.
think that is something kind of over time, maybe we can strike because you can have too much of one. I
Yeah,
would agree.
indeed. What's a cultural practice or saying from Nigeria or France, since you live there, that shaped how you lead?
Hmm. Um, One that I've always liked, it's an Igbo saying. Igbo is my native language. I'll say it in Igbo first and then translate it. In Igbo, it's "Mbommadụ nteta wụtụtụ." And what that translates as literally is when someone wakes up, that's their morning. And I've loved that because it contextualizes something that seems very easy. Like we all know what morning is. It's 7 a.m. or whenever the sun comes up. But then it says to me that no, you have to think about it from the lens of the person who was asleep. And it seems sort of simple, but it's really shaped how
Mhm,
I interact with people as I become very interested to understand how did you sleep and approach this morning? And when
mhm,
are you ready for the information that I want to impart versus when I'm wanting to impart it,
mhm,
kind of thing.
mhm. That's powerful.
Thank
What are you
you.
binge watching?
Ah, I love this question because I'm like, maybe I should do more watching. If I did watch TV or stream, I would binge watch sports documentaries. I am a big sports person.
Uh-huh.
All four daughters play volleyball, two
Yeah.
in college, and the others preparing. So we're big sports, and it's soccer. But I love documentaries because it's
Yeah.
about people performing at a high level
Yeah.
in their area. And then there's a lot of just learning that comes
Mhm,
with that as you hear about their challenges, what they were told they couldn't, shouldn't, wouldn't
mhm,
do, and how
mhm.
they overcame that. I find that really inspiring. So that's what I would watch. I binge read a lot of kind of social science literature because I want to stay connected with that area. Although I do mostly health services research, I am very curious, kind of in economics and anthropology and sociology and psych. What are people publishing as far as research? So
Mhm.
I do find time for that because I do enjoy it.
This has been a fascinating interview, Every. Thank you so much for giving a different perspective on uh, seeing people, truly seeing people, and uh, knowing that it's their morning and we need to meet them where they are. So I want to thank you.
Thank you, Patty. Thank you for the opportunity.